We have begun. We've almost begun. Come on in, we're getting started. Join the party. You're not late, you're right on time. Yeah. No chatting, no chat, no friendliness, none of that type of stuff. It's Friday. You're not allowed to be pleasant. Look, no one's looking more forward to the end of the term. You guys are, we are too. Teachers are like that. How many more classes do I have? You start crossing them off. All right, we're going. Enough of that nonsense. Moving on. All right, we're ending chapter 11. And I just have to really go over the neurotransmitter stuff. That's really what's left in this. There's not a lot to it. Hey, front row. Thank you. So this is kind of where we left it. I just want to review. You know it. Hey, thank you. Got a lot to get through. We're going to get through it. You can be on your merry way. This is we've done so much acetylcholine. We don't have to talk about it. Okay. These are important. Okay, the catecholamines, you're going to see when that construct up there, they're made at almost exclusively in the midbrain. One other area where you see epinephrine is made in the adrenal gland where it gets its name, or former name adrenaline, as is norepinephrine, or formerly noradrenaline. So these two are made in the midbrain. This one is only made in the adrenal gland, and there's a crossover here. These are almost exclusively, there's a couple of very limited exceptions where they are excitatory. That's important. The indolamines, because indole has to do with their chemical, with a particular chemical structure that comes from the way certain amino acids are sort of put together. Serotonin and histamine, to be fair, all of these used in the brain, it depends on what the receptors do, whether it's involved in emotional behaviors or biological clocks. Imbalances are certainly associated with mental illness. I don't like the term mental illness. It's somewhat pejorative, meaning, it's a stigma. Oh, they're mentally ill. It's a lot of times they are chemical imbalances more than anything else. We paint with too broad of a brush. That's just my feeling talking to it. So they're all involved in this. In general, where these dopamine, norepinephrine, epinephrine are almost always, with maybe a limited exception or two, excitatory, these can be, because they play different roles. You'll see serotonin involved in blood clotting. You'll see serotonin involved as not a neurotransmitter, but effectively a hormone that plays a role in the digestive system. So they're not always neurotransmitters, they're biological chemicals, and the same for histamine. Histamine plays that pivotal role in asthma, anaphylactic shock, all your allergies, and most of us have some kinds of allergies. It's the nature of the beast. Okay, and so in that case, they're not neurotransmitters. It depends on where they're in the brain, okay, or they're coming out of a nerve. They're a neurotransmitter. Different things. So there's a lot of variation, and indeed, to sum it up, most of the time when we're trying to control people with those kinds of mental, psychological, psychiatric type of problems, we try to work with these, either make more of them available, work on the receptors. That's where the medications come from. The amino acids this is an amino acid. These are, of those 20 you learned about at the start of the course, glutamate, aspartate, and glycine are all part of those 20. GABA is a derivative of one of them. I don't recall which one it is. And we call it gamma aminobutyric acid, but we always use GABA because that's such a mouthful. In general, glutamate and aspartate are excitatory almost exclusively. Glycine and GABA are typically inhibitory. You're going to see why in a jiff. In general, these are the ones that are associated particularly with those chloride-gated channels. That's what they do. So they make the nerve less likely to fire. That is how, again, sedative hypnotics work, sleeping pills, tranquilizers. That's how alcohol works. All by affecting those kinds of pathways. These are a little less definitive. in what they are. We know about them. We know they exist. Exactly what they do and how they do it is not terribly clear. You might remember I talked briefly about substance P. Maybe you didn't. I didn't make a big deal out of it, nor am I making a big deal out of it here. When I talked about capsaicin creams with arthritis, those are creams that deplete substance. It's a pain mediator. That's just its name. Neuropeptides, because they're short chains of amino acids, 9, 10, 12, whatever. And this is when it says this is sort of way interfering in this, it takes away, it's not taking away the pain, it's taking away our brain's perception of pain. That capsaicin creams are made from an extract of red pepper, because the family name for peppers in general, bell peppers, are capsicums. And certain ones have an abundance of this capsaicin. It depletes that when you rub it on. In my experience, it works on about a third of the patients. About a third can't tolerate it, makes their skin burn, and a third has no effect. But it's been around for a long time. It used to be a prescription product. Now you can just go to the store and buy it now. So it's a well-known substance that works. And why we classify it here is we're depleting a particular neurotransmitter that plays a role. Endorphins are endogenous, which means inside of your body, naturally made morphine-like substances. All pain medicines are basically judged in how they, with regard to morphine. Basically, morphine is the idea, is it 5 times as strong, is it 2 times as weak? We've tinkered with the morphine nucleus that comes from basically an extract. I used to teach a course in addictive diseases. Basically, you take opium poppies, okay? You take opium poppies, it only grows in limited areas around, you crush them, and basically before they begin to blossom, and you crush them, and the sap that comes out of there, basically you cook it, and the first product that comes up, so to speak, from this sort of milieu of liquid happens to be morphine. The second product is codeine. Okay, and they're potent painkillers. We make substances that are very similar to them, hence they're called endorphins. They have different names that are there, so they're natural opiates. We understand the words narcotic. When you talk about narcotics, it doesn't mean all addictive substances. Opiates specifically are narcotic analgesics. That is their classification pharmacologically. You will undoubtedly learn that in pharmacy. And we have tinkered with them over the years. For instance, heroin, which is more addictive, means it just gets to the brain faster. Okay. So we've tinkered with it chemically in such a way to make it go into your nervous system faster. And when you talk about fentanyl, faster still. So it's all things. Some of them were done originally to improve efficacy, and a lot of them, unfortunately, science is a dangerous thing when it's used for bad as well as used for good. That's a whole other lecture. I tried to do that, get them to do this course here. If they had a similar course somewhere, so they said it would be duplication. That was years ago, and I kind of said, I got enough to do. But I had so much fun teaching. So we make those. When they used to talk about a runner's high, when running became popular back in the late 60s and early 70s, it was like, oh, I had a breakthrough, and I felt like I could run. They were trying to run that, 5K or 10K, and finally got there. And people experience a high from a lot of things that we do. I mean, it just, when I'm teaching a class and all of a sudden everybody's got rapt attention, it's like, I got you all. Oh, we all have that in our lives, whatever gives us pleasure. And a lot of times the pleasure is coming from an endogenous or naturally occurring release of these substances. Good stuff. Okay, we want this to happen. Better to be natural. Stay away from that other stuff. That's why they're addictive. So I even tell you about where the addictive disease is a little bit, and we do the second part of today's presentation. And I'm an expert on addiction. I've been addicted to so many things, unfortunately. Don't be me. 40 years of cigarettes, a bunch of pain pills, don't do any of those stuff. Never drank. Okay, all that type of stuff. Gambling, love to do that. Don't do that. So we did win $6 on Halloween night, my wife and I. Big spenders. That's you can imagine we're playing for pennies. And gut-brain peptides, these play a role. They technically are neurotransmitters because they do play a role with regard to the nervous system. And again, some of that, I mean, some of the satisfaction we get when we eat something play a role with regard to this. But you'll learn more about them when you start talking about digestive and AP2. So, that, I mean, there's a lot of stuff that's going on there. And then we're not done. Coffee contains adenosine. Purines, adenine and guanine are the purines chemically. Adenosine is adenine with a ribose next to it. When we take that, it's very potent and it blocks caffeine. Okay, caffeine rather blocks those receptors. It tends to be a potent inhibitor. It relaxes you. It allows you to fall asleep when you're producing adenosine. It plays a role in a variety of processes that you'll learn. We block it all the time because a lot of us start the day, and believe me, I don't know if you guys do it yet. Watch out. If you're not ardent coffee drinkers, if you're going into nursing, you will be. If you use it, I mean, you've got to be on the floor for 12 hours with a bunch of crazy people. You'll be doing something like that. It is addictive, but it's a comparatively easy one. It's easy to take care of. I mean, it's not, it's more about affecting the inside than outside, so to speak, more about irritating your stomach. So gasotransmitters, not something that people are really familiar with and how they work. I mean, these are toxins from auto exhaust, not the nitric oxide, but carbon monoxide, hydrogen sulfide, that's that rotten egg smell stuff. Believe it or not, we make those inside ourselves, and they do play a role because they're so lipid soluble in a lot of different things. The one, as you can see, we're not clear on what they do. The one we understand and surely the most interesting is nitric oxide. I wasn't educated about that. That's how recently, within the last almost 50 years, we have learned what nitric oxide is. Interesting substance. When your blood vessels are in somewhat constricted and they're stretched open, the lining cells give off nitric oxide. It actually dilates them or relaxes them. So it allows blood to flow more effortlessly. And we learned that it plays a role in the brain by opening up blood supply and forming new channels. Memory, very significant in stroke patients, where you basically have to create a stroke patient. You have a circuit that's damaged and irreparable. You have to find workarounds, be able to make new roadways or detours. It's very significant, and I have seen living proof of it because my wonderful granddaughter, who's now 8.5, basically had, you might recall me telling you, she had a stroke when she was born. She has a diagnosis, maybe I didn't tell you, cerebral palsy. And they told my son and daughter-in-law, after a very difficult delivery, it's a product of IVF, as is their son, that they'll be lucky if she sits up and maybe walks, maybe talks. I mean, and now she's just go. I mean, you can see the physical limitation. The motor circuits are damaged. She has contractions on her right side. Her left side's immensely strong, and she can use it and all that stuff. I mean, and even though they held her back a grade, she is doing really well now in sex. She's really starting to get it. Has some emotional aspects, but a lot of that. I mean, when I saw those MRIs, I didn't have the heart to explain what was going on. They didn't know. I knew. I mean, I had to find the right words not to scare them terribly. But fortunately, it worked out. And maybe this played a role in it, maybe it didn't. This is not my area of expertise. Nitric oxide is very famous for another reason. Okay, nitric oxide causes blood vessels to dilate and to remain dilated, so it increases blood flow to particular areas. Pfizer, 35 years ago, came up with what we call $1 billion drug. Probably nowadays they're $10 billion drugs. It's got a fancy name. It's called sildenafil, also known as Viagra. It made them a ton of money, and what it does is it blocks the breakdown of nitric oxide during the excitation phase of sexual, whatever the right word is, sexual. You get the idea. I'm trying to think of the right word. So what it does, and obviously this was like one of these bitter mousetrap things. that people look, because unfortunately, this is something, as you'll learn in repro, that a lot of men particularly start to develop, and it's an increasing amount, probably by age 30 to 40, there starts to be limitations, and then the whole male ego gets involved. So they knew they had a winner with regard to that. So you'll probably go over, you want to examine the pathway, and since then they've came out with a whole bunch of cottage industries and stuff like that. But what it does during the erection phase, it keeps those blood vessels open so that the penis stays engorged or erect. And you might get some of that when you talk about in repro physiology. It's there. Which brings us to cannabinoids, which are basically, if you did not know it, the active ingredient of marijuana is called tetrahydrocannabinol. Years ago, all we knew about this was that when in the human body, it breaks down and changes into a couple of hundred different active compounds. We call those active metabolites. It stays in your system a long time. It's fat soluble. That's why, and many of you, if you're going into an area where you have to have drug testing, that's the kind of stuff that I understand. In some areas it's legal. In other areas it requires medical marijuana, and you have to have, like in this state, as far as I know, it still does, that they drug test. And that, I mean, it's not something that, well, I didn't take any of those gummies that I'd been taking that people do, not that I do them, for X amount of time. It typically stays in your system for about a month. If you did not know it, amphetamines and cocaine, they drug test those randomly 2 to 3 times a week. They have a very short half-life. This is the kind of stuff that stays in hair samples even. So depending on the company that you might work for or what they are involved in, even if they may wonder, well, I have a medical certificate. Well, could that impact you at work? It's your lives. I'm just trying to keep you informed so you know what to do down the road. My not that son, but my next son is he carts hazardous materials around, explosives, propane. He's a hazmat driver. He drives tanks with propane. He's doing more technical work. But I mean, the first thing that happens when somebody rear-ended him in a truck when he was carting explosives a few years ago, the guy just rammed into him. Before he got out of the car, they came over and said, okay, we'll take care of this. So-and-so is going to drive you over to the hospital to have a blood test to make sure that you're drug-free. That's the first thing. Before you even got the report. Gives you an idea, depending on the area you're in, how significant that is. Absolutely true story. So all of this is part of it. It plays a role. We know that there's so many, the active ingredients you hear about today are CBD and THC. The CBD has a lot of, theoretically, it doesn't have quite the effects where you would be like driving under the influence, theoretically. I mean, how it works exactly, and I've never used them, so I don't know. Not in this form. We knew for a long time that people who smoke marijuana, before it had any of these legalities, way back in the day, okay, where they typically stimulated their appetite. They very rarely got nauseous, and if anything, it helped enhance pain medicines. So they were an unusual adjunct or addition to pain medicines, and that's where they were used originally. It was a class 1 substance, meaning that had no medical benefits. We know now it has a lot of medical benefits. So over time, I mean, things were relaxed. I mean, it was you were in big trouble. For many of you, because you're going into healthcare and licensed fields, things like DUIs are very bad. I had that same discussion with my son when he was at Duquesne. And I mean, you're living off campus. Yeah, I'm crawling distance from my favorite pub, the South Side. Nothing that hasn't hit me that kids can do. And I mean, understand, I mean, he's got a very high position in the military. If he'd had a DUI, my guess is he would have had a relatively short career. Fortunately, the one time that it caught up with him in college, not only was he underage, but it was on a weeknight. And I mean, fortunately, all he did was get reamed out by, some gunnery sergeant from the Marines. And oh my God, can they yell at you? To straighten his posterior out. The point I'm making is that now you're at the age where this stuff follows you around. So I want you to be careful. So all of that is really important stuff. So they are inherently there. Okay. So this is the active ingredient. It breaks down to things that may have, and that certainly do have medical benefit, but we produce them naturally, if you did not know. So endocannabinoids. In general, excitatory or inhibitory, GABA and glycine, usually, nothing is complete. Inhibitory because they open those chloride channels. Glutamate and aspartate, usually excitatory. They open up those sodium potassium channels. And there's some oddballs here. When you get to it, acetylcholine and norepinephrine bind to at least a couple of types we call paradoxical or opposite effects. The classic is here. Why your heart rate isn't over 100, any of ours. Your normal heart rate without the vagal nerve would be over 100. It's a measure of health called resting heart rate. If you have a good resting heart rate, your heart's being held in check, and it gives you plenty of reserves. For those of you in sport, many of you even have a lower resting heart rate than the typical person, between 60 and 80. It's the vagal nerve that's secreting acetylcholine. The area where it's always inhibitory is its effect on the heart. Be very aware of that going forward, because that'll be on the test when we talk about, because that's part of the autonomic nervous system for the final. Okay, and then direct and indirect means how fast it occurs. Direct, it alters the membrane right away. So acetylcholine and amino acids, they open those channels, those ion channels. Indirect, what I talked about, those catecholamines, the serotonin, the histamine, all those gases, and those endogenous morphine substances, they work. It takes longer to affect, and if it takes longer to affect, it always lasts longer. It's consistent. Whether it's a medicine we prescribe or whether it's something internally, if it happens fast, it goes away fast. If it happens slowly, it goes away slowly. So all of that's part of it, and I think that's important to remember. That's there. So the neuromodulators it's sort of a nice term where it's sort of in the middle. It's probably more indirect. So it has influences. It's a modifier. That's what a modulator is. It'll cause changes. That's why when I told you about Paxil and Prozac and Zoloft, the reason I got on there and said, look, if you take this over time, it will change the receptor. That's a modulatory effect. It's there. And there's other ones. Remember I was giving you like little analogies, fire or don't fire, or wait a minute, you might want to fire, but you may need to fire later. It's that type of a thing, almost a degree of importance. So the chemical messenger is released that does not directly influence it, but affects the strength of the transmission, all these different factors. And that's kind of the idea behind those reuptake inhibitors I talked about. Altering the sensitivity, that's the reuptake inhibitors. May only be a local effect. So just in general, there are neuromodulators. There's a lot of different things. We think, interestingly, they're not used as much today, but some are still used therapeutically. Hallucinogenic agents might work that way. If you're unfamiliar, there was a widespread use back when I was in college of hallucinogenic agents. If I said Timothy Leary, would anybody have a context? Probably not. He was a professor at Harvard. He started using LSD, which is a hallucinogenic agent. And he said if he wanted to expand, you would turn on, tune in, and drop out. Those are his famous words. He was kind of an oddball. But back when I was in college, a lot of us used that. And I use the term us correctly. Yeah, I know I did that stuff. The statute of limitations has expired. Put away that speed dial of yours. She's going to tell on me. Remember that Woodstock thing? Trust me. Did you watch any videos yet? No. You see a lot of barely clothed individuals, men and women, having a party. All having a great time. No riots, no violence, no nothing. Amazing. So, and this is the whole idea: sodium influx, depolarizing, chloride influx, hyperpolarizing, and they just show it to you. And I'm not going to go over the G protein are the ones with all these what we call second. I'll just show it to you, and it does. It's why it takes longer. Okay, they don't enter the cell directly, and you may have seen. I'm sure we looked at this a little before. In fact, let's say this is dopamine. It takes a while to generate a chain reaction along the membrane and finally release something like calcium or something called cyclic AMP that I mentioned in passing before. You'll get more of this in AP2, and it creates a multitude of things inside the cell. And if I back up, it'll open and close channels then, activate enzymes, do phosphorylation, actually infect transcription and translation, make genetics, making proteins. So they have a lot of interesting effects. So that for your purposes now, the ones that open those ion channels are rapid. The ones that work through G proteins, slower. And that's it. I don't think there's anything else here. I don't do any of this last stuff. So starting, ending at that slide, you don't have to know anything else about that chapter. You don't have to thank me. It's all part of the service. Which brings us to the brain. Whether I get to the brain development, we'll see. Where's that piece? Aha. That piece, dummy. Give me a minute, I'll get there. There it is. So for those not in attendance, yes, find somebody who was and take a picture. I've been doing this for. So, this is the construct for me. The highest order functioning to the lowest order functioning. You've got a lot of these, I would suspect, in lab. This is sort of the way the cerebral lobes, what they talk about up here, cerebral hemispheres, and the cortex, the outer portion where the gray matter is, those are the highest order functioning things. Those are the only ones we really control. That's where we start our commands. We react to that. That's the processing that goes on. There are four, there's actually a fifth lobe for smell or taste, which are very primitive senses, called the insula, that's very deep inside. The four lobes that you have to know, frontal, parietal, temporal, lobes. The frontal is everything. Frontal executes all motor commands, processes information, all that stuff you're doing on a test, determining what to write down right now, listening to me and saying that's important or that's not important. That, ladies and gentlemen, is all frontal lobe. Mathematics, logic, and it doesn't preclude emotions. You understand? I mean, we filter it with emotions. We're like, right now, you're calm, you're listening to me. But there's other times where someone will come to you and you'll be able to, are they hysterical? Did something really happen? All of that kind of stuff gets filtered through. So it's not cut and dry. It's not as cut and dry as solving, an algebra problem. So it's so motor, cognitive, language, reasoning, all of that is frontal lobe. Parietal lobe is sensory, not including the special senses per se. So whether, when we walked into the room yesterday, whatever day that was, and was it really hot? But it's not quite as bad today. That's sensory. Feeling the chair, is it uncomfortable? That's sensory. Okay, any of those kinds of things. Hearing sounds like that we were sensory too, but actual body sensory is very much the parietal lobe, and it also processes those sensations, and everything is interrelated. It shuttles information back and forth by white matter fibers, as you will come to see when we talk about that Wednesday, about how the rest of that part of the brain works. So we primarily sense stuff going on in our body from the parietal lobe. Temporal, a very intricate lobe, but principally sound and balance. Okay, there's a lot more that goes on in the temporal, a very interesting lobe of the brain. And occipital is visual processing. So again, we process it. Same thing with the temporal lobe. You're processing what you're hearing, and then we shuttle that information to the frontal lobe and we react to it. We actually see it, the occipital lobe, what that means to us, what that picture tells me. Somebody, are you guys awake or asleep or concentrating or not? That's all going on. For most of you, I hope you're enjoying this rest. Nobody cares. So occipital is vision. Frontal lobe, in order for us to act, the basal nuclei are about fine motor control. And they receive dopamine, interestingly, which is made in the midbrain. We'll get to that in a second. And that's where the catecholamines are mostly made, in the midbrain. And there's a pathway that takes us to the basal nuclei. And it's an absence or damage to that. Sometimes medicine's impacted. There's a lot of tumors impacted, infections impacted, that create a Parkinson's. Parkinson's is a generic term. So there's a disease, and to me, there's also Parkinson's-like syndromes. You see a lot of different side effects from medicines. So what happens in the basal nuclei, it's fine movement. Oh, I want to reach for this. Now, if I could reach for it like that, that would be inappropriate, or I might have trouble starting it. That's fine motor control. I want to grab something. I'm going to grab it. Am I going to hold it? If I reach for this, I'm going to spill it all over the place and knock it over. And you see someone with Parkinson's, they have very, very difficult time starting and stopping. They have irregular movements. Sometimes it's hard for them to move at all. We call it a flat affect. They're sort of like, when it gets very, very severe. I mean, it's not all, there's no broad brush to use. It can be boxers, they used to call them punch drunk. The best boxer I ever saw, a guy named Muhammad Ali, died a few years ago. I mean, that was the damage he fought for such a long time. We see things like that impacting, unfortunately, with this chronic traumatic encephalopathy, sport and football players, not just football players, but other sports. The 23-year-old guy just committed suicide. I mean, there had to be something. So there's parts of the brain that really we don't understand. But for fine motor control, that's really what they're about. This is conscious. This really is not. But these are still in that same area, this highest order functioning area. As we work our way down, now we're into areas that you might call subconscious. The diencephalon is surrounded by an interesting system called the limbic system. Those are islands or portions of gray matter that have a lot to do with emotions. We're constantly balancing our emotions with our cognitive stuff. It's very, very difficult. So the limbic system is when you hear people, we talked about a little bit when I asked you, many of you knew the hippocampus or the amygdala, rage, and we're going to go over it again. Rage centers, memory centers, all of that thing, everything we filter through our emotions. If we didn't, there would be a whole lot to our lives that are there. It's also, you heard me talking about addictive diseases, where there's also a pathway from here where catecholamines go up to the limbic system. That's the main one for addictive disease. Primary thing that addicts someone, causing an outpouring of dopamine going to that system is really what addicts us. That's the part. It's called reinforcement. It's whatever that desirable feeling you get. It's nice if you get it from doing something that's constructive. Maybe the reinforcement of getting a good grade, or having a really positive relationship, or whatever it is. Building something at home. It's bad when it's popping nicotine hits. Basically, and the faster it gets to you, the more it addicts you. That's what I was talking about. Things turning morphine into heroin. All of those are part of it. We'll talk a little bit about nicotine in this unit as well. So that's part of the thing. So they surround it, but the big thing, the diencephalon, you have three major components. The thalamus, which is the biggest part. Maybe you saw it on the sheep dissection. Just of the brainstem, and basically it sorts, edits, and relays information. All sensory information kind of filters through there. Just saw that. I better send that quickly. Yeah, occipital lobe to that area, which is important. I heard something. Okay, I'm going to shift that up to the temporal lobe, to a particular area. So even just general sensation shoots it to the appropriate area of that part of the brain to process it. Does it interact with it? There's some tie-ins with emotional. That's why it's in close proximity to that limbic system. That's all. I will go over these. This is the general construct. Sensory processing and relaying to the brain. There's a neat thing called the corona radiata, which you may or may not have seen on the dissection. It's white matter fibers that basically take that to the appropriate area of the brain. It kind of looks like a seashell out of it. I'll show you the illustration. That's there. We'll be when we look more into it. And the epithalamus is about sleep. The pineal gland is the epithalamus. That was also in the brain dissection. You may or may not have seen that. And it's odd. We really don't understand. We know it plays a role in sleep because it makes melatonin. A word to the wise: if you have trouble sleeping, the first time you take melatonin, be careful because it affects different people differently. Some people it just wipes them out. They try to get in a car and drive someplace. Oh boy, you're just not. You got to be careful. Things like that. I tell everybody that. I've never taken it. Stepson, takes it pretty regularly. It helps him sleep. Some people have more trouble with it. They don't sleep well. They helps. And the hypothalamus is the link between the nervous system and the endocrine system. It's where the blood-brain barrier is weakest. So where you and I, how it senses, how does my body know my sugar's low? There. How about sodium? How about do I need fluid or do I not need fluid? Am I hungry or thirsty? That's the hypothalamus. And the neuroendocrine system, nervous system is fast, endocrine system is next. It's that same analogy, the same sort of example, rather. Some idiot cuts you off on the road. You do that. That's your nervous system. Your heart racing. Oh my God, nearly killed me. That type of stuff. Your heart racing, your respiration is up. All of that is your endocrine system. That lasts long. Not necessarily long, a minute or two, you probably calm down. That's the interesting relationship between. So you're going to see this is the link. What hangs off it is a very famous structure called the pituitary gland. That's why it links the major gland of the endocrine system with a little tongue-like depression, tongue-like projection of your brain, which you will see called the infundibulum. There. Which brings us to the brain stem. Brain stem, basically, there's no longer any significant processing that goes on. It's really where your presets are. It's really your internal hard drive, if you want to think of it, an operating system. When it's damaged there, big trouble, because it controls the pons and medulla, control breathing, heart rate, all of those types of things we don't even give a second thought about. Blood vessels, how they're working, where blood's supposed to flow to, where it's not, all of those kinds of things. That's really where this is why we call it the brain stem, those three areas. The midbrain is where particularly those catecholamines are made, and it probably is the most developed of these areas. It's one area that's relatively speaking not changed as much from when we're born, so to speak. I think maybe that's the wrong term. But in development, it's one of the ones that stays with us the longest. And by the time we get down to the spinal cord, that's just a relay center. Sending signals out, bringing signals back in. There's no processing. There's certainly processing, as you will see here. Lastly, the second most important area based on its function, and the second largest area, is called the cerebellum. It also has gray matter on the outside. The fact that it has gray matter indicates its importance. All of those are interconnections, synapses. We have them in the cerebral cortices, and we have it in the cerebellar cortices. It is responsible, fancy word, for ipsilateral motor coordination. Most of the way your body works is contralateral. I'm raising my left, my instructions coming from the right. If I'm raising my right, it's coming from the left, right? Correct? Left. That's contra, opposite, opposed. Ipsy means same side. It's coordinating when you do something. When I take a step, it's not just, I'm just not flexing thigh. There's a whole bunch of other muscles, same side, that have to do certain things. My leg, gotta make sure it's not too hard or too fast. Accessory muscles are part of the deal. We give it a second thought. When I tell you, okay, we're done, not be shortly, we're all gonna go, do you think I have to push up this muscle from my chair? I have to close this. I have to do this. You don't think that. You just go on automatic pilot. You're going to your day, or you're staying here, right? But maybe you go out. Maybe you have to run to the bathroom. Maybe you have to do something outside. You just want to stand up. I didn't give it a second thought moving back and forth. I said, hey, I want to go over here and go over here. Coordinates like muscle memory. So many connections. And it works so efficiently for cerebellum. And it plays a role in so many things. It sends signals up, it sends signals down. It interacts with all of those other areas of the brain. Very interesting. There's something called Romberg sign that involves 2 of the 3. For instance, for us to be able to move without any problem, we have 3 things that allow us to move pretty easily. Cerebellum, which coordinates all the motion, your proprioceptors, and your eyes. Did you go over proprioceptors? Yeah. Okay. So if I told all of you right now, close your eyes and tell me where your hands are, I wager everybody would know where their hands are. You'd know whether they were under here, they were over here, they were here. I'm just looking around. On top of your computer, some of you are writing, some of you are texting, whatever you're doing, it's okay. Do whatever you want. But you all knew what it was. That's a proprioceptor. You know where your body is in time and space. So if I close my eyes, I know I'm standing here. I'm familiar with where I am by my proprioceptors. I can walk back, right? As long as you have 2 out of the 3. Your eyes, if you watch somebody, a diabetic with peripheral neuropathy, they can't feel their feet. Okay. Those are your proprioceptors. So they walk like this. They actually have to, they have this to know where they're supposed to be going, but they have to actually look, make sure their feet are in the right place. By the same token, I don't have that problem. I don't feel my feet, so I can just close my eyes. And I know where my nose is, I know where my elbow is, my shoulder, my forehead, right? That's called Romberg sign. As long as you have 2 of the 3 of those, you're able to do all those things. This is the basis of something that none of you should be familiar with, called the field sobriety test. Okay. Maybe one of you. So what happens in the field sobriety test? They can have, sir or madam, would you get out of the car? And then I want you to close your eyes and walk a straight line. Or they'll tell you, close your eyes, touch your nose. And they end up here because they have no idea because their cerebellum is gone, the alcohol hits it. And they fall over laughing. That may be funny to you, but it's going to give you a night in an uncomfortable area. You know what I'm saying? That's important. So that's your cerebellum is probably the most underrated area. We'll look at it anatomically as things go on as well. That's my base construct. Higher order functioning to lower order functioning. What they call it. Let me see if I can get it. It kind of comes from all this. Basically called cephalization. As we have evolved to be the dominant species, though you might argue with that. I mean, it goes up higher. So the more we have at those highest levels, okay, basically we have higher order functioning. More so. I mean, my dog's a bad example because he's not brilliant. He's not going to be, but you understand, you have certain, and understand that there's a lot of certain species are very, very cognitive. A lot of dogs can learn language up to maybe 1,000 words, particularly ones that they use in the military. There's a wonderful series of books about that. They're fiction, but they're written by a veterinarian. So the brain and the spinal cord, they start as a tube. And what happens, this tube, and I'll go over it because we don't have enough time. Effectively, it's a narrow tube and it's filled with fluid and it widens. And as the areas enhance and expand and develop more connections, then they form gray matter only in two areas, the cerebrum and the cerebellum. And some of them have no gray matter. You're going to find that there's some gray matter in all these, but the ones that are on the exterior, by definition, are called cortex, or the plural is cortices. And that's part of this development of the brain. The brain's fascinating. And as time goes on, it begins to it contorts, it compacts, it's got a very limited space that it can occupy. And there's all those things you saw in the brain dissection, all of those folds. It's that folding thing again I keep jabbering about. Hills and valleys, sulci, indentation, gyri, mounds, right? You saw all those. The sheep doesn't have as many as we do, again, or the sheep would be dissecting us. Maybe not. Depends if we gave the sheep a hard time. All right, that's basically, I'm going to go over this in more detail. So have a great weekend. Monday's the exam. This was the introduction. We're going to revisit this starting Wednesday. Thank you once again.